Good afternoon, everyone. It's a pleasure to me give the welcome to the new IWC forum, to the CISA Forum. And in this opportunity, we are going to talk about the risk contract effect. But before to moving on, I leave the word to Henk, that he's planning to say something.
Thank you, Professor Marasco, colleagues. It's my pleasure to be here, and as you all know, next year we will celebrate our 20th year anniversary of IWAS. And I think this was probably not possible if this nice institute here in IRCAD was not established in 1994 by Professor Marasco, having the vision that we need to be teaching colleagues in endoscopic surgery. And I think his extraordinary achievement has basically led to the foundation of our society. And as Newton already said, we stand on the shoulder of giants. So I think I was really fortunate to be able to stand on the shoulder of Professor Marasco as a giant with the vision of creating this tool. And of course, I know that his achievements already have been acknowledged at the highest level by even by President Macron already in 2021, receiving the Commander of the Legion of Honor. But from our society, of course, we want to show our gratitude, and we have established a prize some years ago in the dedication of one of the pioneers of wrist arthroscopy, Terry Whipple. So this award was created to be given to colleagues who've contributed a lot to wrist surgery and wrist arthroscopy, but also to the dedication of teaching. So this my great honor that on behalf of the International Wrist Arthroscopy Society, I can present this award to you, thanking you for the foundation you've laid for our society many years ago, and also with expansion over the world, this has really led to the stimulation of wrist arthroscopy. So we're very grateful. So I would very much like to present this award to you, and I'll read the text on the prize. It says, Professor Jacques Marasco for his immense contribution to the advancement of wrist arthroscopy. So we thank you very much, and I would like a great applause from the room here, thanking you for your contribution to our society. Thank you very much.
So thank you very much. I think really for me it's a great honor to receive this Terry Whipple Award, and I just regret not to be with you in person, but you see behind me that really I am in a very strong surgical workshop. That's true. No, it's a familial chalet where we are at this time always. I just want to say that it is very special for me because it shows a fantastic growth of IWAS within IRCAD. And this award is not mine. It's just for all the team. That means the hostess, the organizer of the course, the audiovisual team. So really thank you. And I want to have a special word also to Christophe Matula, because you know that without Christophe Matula in IRCAD, nothing happened. So thanks a lot. It's really an honor. And you know that we want to continue to work together to advance minimal invasive surgery in your specialty. Thank you really a lot. Thanks.
So the award will be waiting for you when you return to Strasbourg. We'll keep it in a nice box, very safe. Thank you again.
Thank you. Thank you.
this is a small gift from PCO. We don't need to present anymore. PC, professor who couldn't be with us live this afternoon, and he gave us his recording of the lecture. It was the first lecture. I would just like to say that he gave this lecture in the Japanese Society in Nara, the Congress in last year. And so we can launch his video. Maybe he will join us live for some question if you have any question during the session.
Arthritis, which is, we do not do a lot, but I think there's some good feedback. I think post-traumatic cartilage injury can happen in many occasions, like intraarticular fracture. Sometimes focal injury to the cartilage can happen even without a fracture. And sometimes, for example, we can see this sort of conjugal bruising. Although some people said that it may not call predisposed to osteoarthritis, but it can be cause of continuing symptom. And some patients after trauma with different type of disease. Actually, in our analysis of the continued pain of the distal radius fracture, we published 2008, 43 patients. And in fact, we have found a high proportion of conjugal damage. Out of these patients, 86% has cartilage damage, among the other type of the intraarticular abnormality. So certainly, this is can be cause of the pain. To diagnose cartilage disease, actually can be difficult. Clinical symptom is hard to differentiate. X-ray is usually not useful, and MR is unreliable. Some said that cone beam CT alpha can be helpful. But in fact, most of the time, we use arthroscopy as a diagnosis. We like to do it under local anesthesia, patient completely awake, so that actually I can explain to the patient the finding. This is understanding about the arthritic condition of the joint is very important for subsequent management. And then we continue to use it as our main stage of the diagnosis. Management of cartilage problem has been difficult for the risk. The main reason is because we don't have the much research. This paper by Elizabeth Hackett's group actually reviewed all the patients. Only 26 articles is related to conjugal repair and treatment in the wrist. And there are actually no consensus on treatment. And compare at the same time, there are almost 10,000 literature on the knee. So actually, we are much behind the major joints. So I think there's much work has to be done in this area. In terms of treatment strategy, in the early stage, we still try to either do a symptom control or try to repair or reconstruct the cartilage. It's still reconstructible, while in the late stage, it's mainly on the salvage procedures. So chondroplasty in the small joint has been used and reported in the small lesions, such as when it's less than 5 millimeters. And generally, you can actually see very clearly in the arthroscope. And what you usually do, you can also use a microfracture, but most often you're using small KY to drill down to the subconjugal bone area to induce bleeding. However, unfortunately, there's no systemic report on outcomes such as microfractures. But in our experience, actually, many often simple debridement can work. For example, this patient is a young student who was a dorsal wrist pain for 3.5 years after a previous distal radius fracture, and it actually has a normal X-ray. So in arthroscopy, it's not surprised to find some conjugal lesion. Like in this case, there's a cartilage lesion over the proximal the scaphoid, but more significantly, there's actually a lesion over the radial styloid, and also a full thickness lesion over the dorsal rim of the scaphoid, accompanied with some synovitis, which is a hallmark when you do the arthroscopy. When you see synovitis, you have to check the cartilage because it's always present. We simply do the synovectomy and also do some debridement of the conjugal surface. And in 9 years, 8 months, we follow patient, no pain. So actually, a simple debridement works. Second case, engineer with a wrist pain for 1.5 years after a foot injury. Again, you can see a major significant dorsal lunate fossa cartilage lesion, a full thickness 6 × 6 millimeters. We perform synovectomy and simple debridement, and we follow up the patient against no pain. So in fact, it's not uncommon to see a simple treatment can already work for this sort of cartilage lesion, not necessarily to a major treatment. However, not all the cases will behave the same. Like this case, it's actually one of the earliest cases that stimulate my idea. It's actually a young manual worker, engineer, who had a distal radius fracture, treated conservatively. Radiologically, it's not so bad, but in fact, he has continuous dorsal central wrist pain for 7 years. And this actually affected his work. In fact, I did 2 arthroscopic debridement. Every time I saw that it is a chondral lesion right over the dorsal half of the dorsal lunar fossa. I did debridement year 2000, many years ago, and 2003. Every time he improved for a few months, but symptoms keep coming. So I have to think about the effort, and that's actually stimulated me. Finally, in 2006, I first time used this device, the OX device, using the smallest diameter, the traphize, a 6 millimeter traphize, which can reach the dorsal part of the wrist through the radiocarpal joint, and then through here, we can remove the trunks of the diseased subchondral bone together with the diseased cartilage, and then at the same time, my partner, who is very good in sport medicine, helped me to harvest a bone graft, also chondral graft from the lateral femoral condyle using the same size of the traphize. And that actually is technically not very challenging. The most challenging is how to place the traphize inside the wrist. But once you're inside the wrist, you can actually push the graft easily under direct visualization. Also, chondral grafting can be positioned into place neatly. And this is actually very stable. There's no need for immobilization. You can actually move the joint right away. So this is 4 months after surgery. Actually, patient we have very happy, and also symptom is free, and we can see a very good incorporation of the osteochondral graft there. This is some 16 years after the follow-up. I follow patient every 1 or 2 years, but the patient is still very happy with no symptom, very perfect wrist function, and no arthritis, and the knee, there's no knee pain. So this case sometimes comes. Another professional dancer have a dancing injury in 2007, resulting into an osteochondral lesion in almost the same place. So you will use the same strategy, taking a 30 millimeter long osteochondral graft into the same place. And we can see that it's actually usually placed quite neatly right into the place. There is a small residual defect, which is less than 2 millimeter. We can actually ignore it. We have a revisit about 29 months later. You can see that radiologically there's a perfect incorporation of grafting. And we also actually in the rescope, we actually see a very nice healing of the osteochondral graft with the hyaline cartilage forming. Here is the graft, and there's also minimal junctional defects. And the results sustain, continue, and this is a 10-year 4 months after the forward. You can see that these patients still maintain good function, despite actually you see that she actually need another surgery on the pituitary joint later, but it doesn't affect the original result on the radiocarpal joint. Another patient actually is slightly more complicated, actually a skier injury, young patient who suffer not only just a traumatic injury of the lunar fossa, but also as concomitant symptom of ulnar impactions together with a type 1 CT abscess tear. So again, I first do simple debridement but failed. So after 3 or 4 months, I decided we should go ahead for the 3-in-1 procedure. I performed the ulnar shortening osteotomy. I do the arthroscopic repair of the 1 CT abscess tear. And then at the same time, we try to graft the osteochondral lesion. And in fact, you can actually need on the second look, there's the osteochondral lesion a little bit extended. There seems to be a dumbbell type of the lesion, one more on the dorsal side, which is measured 10.8 millimeters. So this is the first lesion on the more dorsal aspect. So we observed from the 4-5 portal, and then, we observed from the 3-4 portal, and we actually put the traphize from the 4-5 portal, and this is, we tackled the first defect with a 6 × 12 millimeter osteochondral graft, and then subsequently we changed to the scope to the 4-5 portal, and then because we want to direct to the more central part of the osteochondral defect. So this is the second punch. We direct from the 4-5 portal to aim into a little bit more central position of this osteochondral lesion, and do the same to remove a chunk of the osteochondral bone, 6 × 12 millimeter, and then put it another one back into the position. So these are 2 osteochondral grafts placed in the dorsal fossa. So again, you can see that there's a very nice healing of the graft. And clinically, because of minimal invasive surgery, it achieved also excellent function. So actually, we published this paper quite some time ago for patients. Every symptom duration is 28 months, and the size of the lesion is all located in the dorsal lunar fossa. And the report average follow-up is 9.3 years. Actually, has an improvement in all aspects, the function aspects. There's another case that we did later, a little bit later, a young lady who was central wrist pain after taking care of struggling patient. Radiological is normal, but we again see the very classical lesion, a dorsal lunate osteochondral defect. So we performed the similar technique, taking graft from the lateral femoral condyle. Apparently, we would like to treat this in the same way. But unfortunately, during the final insetting of the graft, we found that actually it was a little bit overshoot. So you can see at the end, there's about 2 millimeters of the graft, which is sunk down below the surface. And it's very hard to restore it. So finally, we convert it into a little open graft in order to jack this graft a little bit up so that it can level with the articular surface, and then we can put on a screw. But apparently it doesn't affect the outcome. The graft still heal well, and the patient, this is 3 months after surgery, already obtained very nice results. And this is just a few days before I came here. She's still working as a clinical assistant, very good hand function. The graft healed very nicely, and also minimal donor defect. So in summary, I think the focal conjugate lesion is something that we need to address. I think arthroscopy is always the gold standard in diagnosing this sort of disease. And I will recommend a simple treatment first, debridement plus or minus chondroplasty under local anesthesia as an erosion management. Those patients with continuous symptom, and particularly with the full thickness chondrulation of below 8 millimeters in the distal radius, we will consider osteochondral grafting. And the early mobilization will facilitate healing as well, enhance outcome. And we have encouraging result at least at 9.3 years follow-up or even longer period of time. Thank you very much for your kind attention.
So you may guess that it's a really challenging topic, and now I'm really happy to welcome Pablo Nicolás López Osornio from Barcelona, and he will share with us his experience concerning this challenging problem. Thank you, Pablo.
Here we go. First thing, I have no conflict of interest to disclose. I'm going to talk about the arthroscopic perforation, but first I have to say that there is few lectures concerning the chondral injuries in the wrist. As Dr. Pisijo has already said, Hager and Anderson made a good research concerning this type of injury, and they concluded that, first of all, there is a lack of knowledge with regard to treatment of these injuries in wrist disorders. Second, there are cartilage injuries can be found in up to 32% of all wrist arthroscopies after trauma, and that's a huge number of patients, so we'll have to know how to deal with. And nowadays, no guidelines can officially be recommended, but I will try to give you some advice concerning this. We must distinguish 3 main groups of treatment for the chondral defect. We have a high, a medium, and a low complexity surgeries, depending on the surgeon's skills, price, or logistics needed to perform them. But the subject of my lecture will be only the perforations. If you think about it, usually the higher complex is the treatment, the least frequent is performed. That means that looking at this treatment pyramid, most of the time you will probably use more frequently nanofracture than MACR or free graft. And that's why I'm going to talk specifically about this low complexity but reproducible treatment group. What do papers say? Nanofractures are better than microfractures, as well as nanofractures are better than drilled perforation, and drilled perforation are even better than a simple key wire. At least the drill has an helix and a fluid that allows us to remove the debris from the perforation, but you must take care about this because you cannot drill at high revolution. And it's clearly not recommended to use a single key wire, and you will see why. We also have a large number of papers concluding that nanofracture plus scaffolds are a better option than an isolated nanofracture, especially on huge defects. And what are the differences between the micro and the nanofracture? You have 3 main differences: the depth, the width, and the shape of the fractures. The width, you have the nanofracture having 1 millimeter instead of the microfracture 2 or 3. You have the depth, nanofractures about 9 millimeters and microfracture 3 millimeters, and the shape. The nanofractures are tubular, while the microfractures are like a cone. Going to the surgical room, it means that you can perform a better and significantly higher number of perforations with nanofractures systems instead of microfracture systems. Here you have another comparison on a microscopic view between one and the other kind of perforation and the different brands devices. I suppose that that some of you are thinking about the use of a key wire for making the perforation. I hope this slide clarified your thoughts. It's clearly not recommended to use a simple key wire to perform them. Key wire added to a power tool, drilling up to 2,000 revolutions, seals the trabecular channels, avoiding the migration of the stem cells from the channel. So that means that you will have performed absolutely useless perforations. Here you have an augmented electron microscopy view showing us the clear difference between one and the other type of perforations. This device comes from the USA. It's called the nanofracture, and you have two different types of tools, one with a distal angle of 15 degrees and one full curved. This is the nanofracture device. You cannot find a more simple device. As you can see, the mechanism is really easy peasy, composed by three different components. These are the three steps to perform the nanofracture. You put it on place, then a softly hit with the hammer, you gently remove it, and you start again 2 millimeters beside. These are some examples of microfractures at the left of the slide. And on the right, you can see a tool, just a mix between a micro and a nanofracture. This is called the Power Peak, a power tool that can perform holes of 4.5 millimeters depth and 1.5 millimeters depth, having a special shape on the top that permits to remove the debris, not sealing the trabecular channel. It's a better option than the microfracture, but it's not the best one. This is a nanofracture. The different steps. First, you put it in place, then slightly hit it with a hammer, and you finally remove it, having a small hole, having this final picture. These are some other videos concerning, in this case, it was an ulnar impact syndrome with a severe synovitis, and we found this control defect. At the right side, you can see the initial nanofracture, better than a microfracture. And sometimes you have a huge defect, or it's deeper than, and you're not obtaining a bleeding perforation. You will have to use a bar just to remove first the superficial debris, and then to continue making the nanofracture. At the left side, you can see the classical fibrosis brand. It's just in the scaphoid, in the lunate bridge. And these are the different steps. Always remove the debris. You can use a curette, you can use a shaver, till you find a bleeding bone, and then you add these nanofractures until you have seen. This is using ischemia. You are not removing, and you can see the bone bleeding. Doesn't matter if you finally use a heel or a scaffold, always perform perforations until you find a bleeding and a healthy bone. In the top you can see using a heel, and on the below the pictures you can see using a scaffold, a chondrogite scaffold. Okay. And what about if you don't have any specific devices? Then can I recommend you these key wires coming from micro corkscrew Arthur's device, having a 1.1 and 1.7 millimeter diameter resistant key wire. And sometimes you can hit it with a hammer. Never use a powered drill, a powered tool, please, because you will seal all the trabecular channels. And finally, if we transfer all the scientific knowledge coming from other joints, like the knee, like the ankle, and even the hip, and we follow the recommendation of the International Cartilage Repair Society, we could say that for the stages 1 to 2, you can use the nanofractures, and for the stage 2 to 4B, it's recommended to use the nanofractures, adding some kind of interposition. You can use a scaffold, you can use a shell. We don't have enough data to recommend one or the other, but I sure prefer, in my personal opinion, to use some kind of scaffold or interposition dermal graft. So, summarizing, nanofractures, you have to remember that are better than the microfractures. If you use a drill, please use it at low reps, to avoid sealing the trabecular channels, and please never, never, never use a powered key wire at high revolutions. Okay. So, message home: chondral lesions are frequently overlooked and undertreated. Most of the treatment can be performed by arthroscopy. There's life beyond the arthrodesis. We go too fast to the arthrodesis in the wrist comparing with other joints. And always remember, perform the nanofraction. And finally, I would like to say thank you to the whole IRCAD team for your friendship and your warm hospitality, and congratulations for making better and bigger this incredible course. So thank you very much.
Thank you. Thank you, Pau. I want to call Lorenzo Merlini from Paris. He will talk about arthroscopic interposition.
Thank you, everyone. Hi. So I'd like to acknowledge Christophe and all my friends from the Parisian team for their support and for describing the technique, and also Pedro from Spain for sharing his experience about his dermal interposition technique. So, as Pablo said, if you have some minor defect, you can use without any problem microfractures or nanofractures or perforation. If you have moderate chondral defect, PC is a good technique. If you have wider defects, then you can move on to interposition that allows you to cover wider areas of arthritic bone. So this is true for chondral defect, post-traumatic chondral defect. This is true also for beginning arthritis, especially in young people. And the goal is to try to delay more aggressive procedure and not burn any bridges for later on. So for this, you can use two main options. One of the main options is tendon interposition. This is a technique for post-traumatic radioscaphoid arthritis described by Christophe more than 10 years ago. So the goal is to fix a free graft of palmaris longus, for instance, or a hemi-FCR if you need to, and to fix it only in one bone spot, which is the radial styloid, after a time of debridement and resection of the arthritic area. And then using the capsule and the different volar and dorsal portal of your radiocarpal joint, you can pass the free graft in and out of the capsule, as you can see. So for the dorsal part, it's quite easy. You take a limb from the 1-2 to the 3-4, and then out of the capsule, but deeper to the extensor tendon, back to the joint from the 6R, and back to the 1-2. So that creates a triangle in the dorsal aspect of the wrist. And then you can do the same volarly using the volar radiocarpal portal and the ulnar one, okay, to create the same construction volarly. If it's a slack 2, for instance, then you can also stabilize the scapholunate to prevent any worsening. So this is the passage from in and out of the joint, okay? And then at the end, as you can see, you create an interposition between the scaphoid here and the radius. It's not only an interposition, it's also a hammock effect, okay? It will support your proximal row compared to the radius, and then putting the knot back inside to finish your interposition. So this is the kind of X-ray you can expect. It's not a perfect X-ray, of course, but you can see that there's a small increase in the articular space between at the level of the former arthritic area. Same option, same possibility, different technique for mid-carpal arthritis. You have this technique of capsular fixed free graft interposition using the MCU and MCR portal dorsally and the central volar portal volarly. And I'm moving to the mid-carpal here. As you can see, you can use this portal, and with this portal you can use a radial and an ulnar capsular approach. Okay, two separate holes. So the volar part of your interposition will be fixed volarly to the capsule. So you don't need any anchors, which is good at the mid-carpal level. So this is the passing of the different limbs here from dorsal to volar, crossing the sutures, and then back from volar to dorsal, or all the way, whichever, and creating like a crossing of the limbs under your capitate. And then by doing so, you have once again this hammock effect between your second and proximal row. And as you can see here, you have the two limbs of the interposition crossing between the capitate and the lunate here. So if you have a avascular necrosis of the capitate or a post-traumatic lesion of the capitate, then you can interpose and once again have this hammock effect to support the second row this time. Same thing for CMC, okay? If you have a post-traumatic arthritis in young patient and you want to put any implants and you want to win some time, then you have the arthroscopic resection possibility of debriding the arthritic areas of the trapezium and, if needed, of the first metacarpal. And then, after a time of debridement with the shaver and then the burr, as you can see, I'll move on then to the rest, because this is only a resection. You already knew everything about resection of the CMC. Then at the end, you can harvest a free graft of palmaris longus also. And this time you don't use it as a different passage. You create like an anchovy, like a little cushion of tendon, like this, okay, by doing several knots with a tendon. And then with sutures, you can help yourself and enter this interposition into the CMC joint and fix it to the capsule with the sutures, okay? And it will be stable anyway. Sorry. It will be stable because the space is quite closed, and since you did an arthroscopic approach, the capsule is still preserved, so once the interposition is inside, it won't come out, okay? So here you have the interposition coming from the volar portal to the dorsal by pulling on the suture. Okay. What's interesting, as Christophe said this morning, is that if you manage to do a second look, for instance, for ligament repair or something later on, in most cases you will go inside and you will see the tendon like it was before, as it was kept alive by, I don't know, synovial fluid or biologics, and usually the tendons stay alive, and that's why the interposition keeps functioning in time. So that's for the tendon option. Now you have also the dermal allograft option with use the synthetic patch for shoulder reconstruction. Okay, you have several options on the market, and this allows you to cover wider area. You won't have the hammock effect of the tendon, but you will have a coverage option that's really interesting. And so this is the same example with the radioscaphoid arthritis. Then you can, with the dermal allograft, creating 3 different portals, debride, remove the arthritic area, put some anchors into the dorsal and volar rim of the radius to secure your patch. Then you you prepare your interposition, your dermal allograft to the right size that you measured prior to the surgery, and then secure it on 3 different points to have a good fixation. Put the graft inside and fix it to the dorsal and volar anchors that you already prepared, and put the last anchor here, for instance, in a radial steroid. But you can do the same in the lunate fossa, you can do the same in mid-carpal or in the CMC, wherever you want. So this is all Pedro Delgado case. It's more expensive, okay? Synthetic patch costs more than a tendon, of course, but the good thing is that you don't need to harvest anything. You can cover wider area than a tendon sometimes, and you can also play with the thickness, because if you want to fold in 3 or 2 your patch, you will have more thickness. For instance, Eric Wagner in the US has presented a nice technique where you use it as to enhance the results of a proximal row carpectomy. Okay, so you add more thickness between the capitate and the lunate fossa to preserve the cartilage. What's interesting with this technique, either tendon or dermal allograft, is that it's a non-burning bridge option, and that you preserve the functional results. You can keep the range of motion that was existing pre-op. It's very efficient on the pain, and it can last, it depends, several years. Sometimes it will last only months in very active patients. That's a failure, but in most cases it will last years, 5, 10, maybe more, 10 years. And that's a good thing, because you have to explain that to the patient that you're doing this to win sometimes before doing something more aggressive if needed to. That's not always the case. This is how you can measure the graft before the surgery. It's a good trick with an axial view of a CT scan. Okay, so what you have to get from all this is that, of course, it's not always a definitive surgery, and that's the whole key point. You have to discuss with the patient. You have to select the right patient, because some of the patients won't be happy with it. they want a final aggressive surgery, not to keep any Damocles swords above their head. But for young and active patients, it's a really good option for the perspective in the future. And if you have a strong fixation, either to the capsule or to the bone with anchors, you can have a quite early mobilization. Thank you very much. Thank you for the organization.
Thank you, Lorenzo. So we have time to question and some comment. Any question from the floor? Any comments? Okay, I have one question to Paul. Paul, do you have any experience? There are some devices that some commercial houses have that you can put in your shaver to do the same procedure that you have. Do you have any experience to do that? Like power peak or something similar? It's very frequent to use in the knee.
Yeah, exactly. The problem is that the depth of the perforations are only about 4 and 4.5 millimeters. And it's recommended to have the perforation over 9 to 10 millimeters. It's very useful because you finish all the perforation in 30 seconds, but the thing is that probably you will have to go deeper to free the stem cells from the underlying bone. Okay.
Okay. What question?
I have just one question for you, Pablo. When you make this perforation, do you assess after with an MRI if you have some new cartilage, or it's just like a synovectomy with...
No, exactly. The thing is that it depends about the quality of the MRI. As you already know, you have different software concerning the MRI to assess the improvement of the cartilage. And you can see it's not exactly a cartilage. It's sometimes like you can see on a second look after a distal radius fracture, you see some tissue covering the defect. And in these cases are better than the regular tissue that you find after a distal radius fracture, because you have, if you use, for example, a scaffold, you use something thicker and being more stable, you will find something more stable also in the second look.
Actually, I have first just a small question for Pablo. Could you remind us, please, because your technique is very seducing, why we shouldn't use small key wires? Exactly, what is the question? It's only because it's not recommended, but what is the precise reason?
You can use a small key wire, but the thing is that you don't have to use a power tool with a key wire, because if you use a key wire that is a flat wire, then you will seal the trabecular channel. So sometimes when you are performing some kind of osteosynthesis and you use the drill, you can smell sometimes the burning bone. If you transfer this to a small hole, you will find that after using a key wire at high reps, you will find all the trabecular channels without any kind of blood. Okay, so you can use a key wire, but you will have to use a hammer, not to use a power tool.
Okay.
I have another question for both. You are in the research lines to try to preservation the cartilage. What do you experience, or if you heard something about it, using the orthobiologic is very growing up in orthopedics specialty, and they use the stem cell in the treatment on wrist osteoarthritis. Do you have an experience? Do you have heard something? Last year it was on a World Congress in Paris about the stem cell, and it's growing up this research line. This FAT or BMAC?
I think personally, I think it's the future. Probably we have, if we compare with the other joints, in the wrist we really go fast to the partial arthrodesis, and it's impossible to think about it in the knee or even in the ankle. So I think we must achieve this, and probably the regenerative treatments will be the future in these cases of not massive condyle defects, but smaller or medium condyle defects. But the problem, for example, with the stem cells, thank you very much. With the stem cells is that you have a lot of different brands, and you can compare sometimes the density of the cells in every brand. So that means that you have a lot of bias making some meta-analysis or long-term studies. First of all, we will have to make some consensus about the density of the cells for having real studies about the final results. No? We have to deal with the different brands, and I think that's the first step to be able to present some clarifying results. But I think it's the future.
I think so too. My input is the same as Pau. I think it's the future. The only problem that we have is that we lack the data for once. And for instance, in France, if you want to do some stem cells or some fat transfer from the abdominal fat tissue, you are doing what we call the living cells manipulation. And that's something not really authorized, not really forbidden. It's a gray area. But if you want to do it, you do it as a rogue surgeon. And if you have any problems, then... So it's most of the surgeons in France, they don't do it because of the regulations, mostly. And I think that's one of the obstacles that's a problem. I don't know in Spain, how is it, but...
Yeah, Gustavo?
I have two questions to Lorenzo. Lorenzo, my questions regards about the slack wrists cases. I agree with you in the point of the trying something before a salvage procedure, a more aggressive procedure. My first doubt is about interposition versus only resection. What do you think about that? Because several cases or several series comparing interposition or not in other types of resection or arthroplasty shows no difference. So what's your opinion and how do you deal with this in the wrist? And second question is, in the case of slack, you try to postpone. Do you be satisfied only with this resection and interposition, or do you add another kind of stabilization procedure in order to try to improve a little bit the biomechanics and to make this wrist to endure more?
Very good question. Thank you, Gustavo. First question. I think it depends what you resect. I think some of the area that you can resect can be self-stable because of the surrounding ligaments. Okay, for instance, the STT, as we described with the technique described by Andrea, if you resect the trapezoid and trapezium proximal surface, it's self-stable. If you don't do a too large resection, it's self-stable, and probably you don't need to interpose something at this level. Some other area, if you do a resection on an arthritic, for instance, the CMC, usually on the X-ray, if you don't interpose anything, you'll have a collapse after the X-ray. So, are the patients worse if you don't do any interposition? We need some comparative study. I am more confident if I put something to maintain the space open. That's mainly a theoretical perspective. I think if the X-ray shows the space, I sleep better at night, and sleep is very important for a surgeon. So, that's my opinion for your first question. For the second question, most time I don't do anything strong to maintain the space open. I've done a few cases of suspension. For instance, for the CMC, I've done a few cases of suspension between first and second metacarpal. But same thing, if you already interpose something in a joint, I don't think that's always necessary. But if you don't, and if you do only the resection, yes, I would do.
Just a little comment, Gustavo. For when we do the interposition, we stabilize the scapholunate joint by doing a kind of stabilization, but we don't stabilize it totally because we're just working on degenerative tissues. So we feel more confident. I totally agree with Lorenzo if we do an interposition.
Of course, not invest so much as a total reconstruction, but doing a Matulan technique, for instance. Do you think it's something?
If you do a slack 2 interposition, you have to treat the cause. The cause is the slack scapholunate instability. Then you have to stabilize, not necessarily reconstruct, but at least stabilize the scapholunate to prevent any iterative evolution.
Yeah, we are in the same page. I agree completely with this.
We have a question for the panel from the internet after we have. Yes, first. They thank everyone for the great forum. And does the soft tissue interposition arthroplasty for focal lesion are indicated And what are your experience for the focal lesions interposition, for example?
Real focal lesion, I'm not sure you have to necessarily move to an interposition. I think if it's small enough, you can do either nanofractures. I've been doing some cartilage graft also. I'm quite happy for small lesions. So not necessarily.
Yes.
But,
yeah. We already answered with all the lectures. And maybe, Lucian, you have a question?
I had a question for both. Did you do second looks? Like PCO in his lecture showed us some second looks in which the graft looked very nice. Do you think it's necessary? Did you have the failures in which you did a second look and saw something that didn't work?
Of course, I have failures. And the second look normally is in the failure, yeah. Okay? I had probably, answering the first question of Alam, I normally, for focal lesions, I use a chondrocyte. Chondrocyte is a membrane used to cultivate chondrocytes. It started 25 years ago. It comes from Switzerland. And it's really useful for small defects. For me, it's much better than using, and the papers said exactly the same, is more useful than using only the nanofracture. The thing in my country is the price. You are talking about 2,000, 2,000 and a half, or even 3,000 for a 2 per 3 centimeters scaffold. So it's really expensive. But I think that it's better to put something instead of having all the stem cells flowering inside the joint. Okay.
And what are the exact indications? What are the boundaries of nanofracture with or without your membrane?
The fact is that the nanofractures are indicated if you have a chondral defect over the 50% of the thickness. If it's under if it's under the 50%, you can use only nanofractures. If it is over the 50%, then you will have to remove the debris and then to put a membrane. Okay.
Thank you.
Christophe have a question.
Yes, I would like to add a comment about the focal lesion, because in my experience, I only remove the subchondral bone depending on the size. But if we speak about focal lesion, it's 1 centimeter, 1.5 centimeters. And we had a lot of discussion with PCO regarding on the opportunity to remove a part of the knee to put, it's beautiful, it's wonderful, technically fantastically done, but normally, you remove something and you have sufficient soft tissue covering the area, and it's sufficient in my opinion and in my experience too. So for focal lesions, so take care not to destroy some joint to repair another one.
So if you understand well, what is the exact definition of the focal lesion for you?
For me, a focal lesion is 1 centimeter, 1.5 centimeters, not more. After that is a huge lesion in the wrist.
Okay, so only debridement. Okay, thank you.
Only debridement.
Okay. We have a question from sorry, Mireia first.
To all the panelists, thank you very much. How do you face the post-traumatic dorsal lunate chondral lesion? Not down, but up.
Good question.
Dorsal lunate defect?
Yes, post-traumatic dorsal lunate.
No perfect option at this stage. I've been doing with the cartilage graft once with the autocar technique, where you harvest some bits of cartilage and you mix it with the paste. It creates a paste. I've been doing a case once on the lunate, once on the capitate. Yeah, it's better than before. No one knows what we will like 10 years after. Maybe a simple resection also of the dorsal rim of the radius could be all helpful, because then they have less pain in extension.
Thank you.
Mireia, normally synovectomy, arthroscopic synovectomy, because sometimes the problem is not the defect of the cartilage, but the synovitis after the trauma. If the defect is enough, you can make some perforation. And sometimes it is not clear pain in the dorsal part of the wrist, and sometimes I have to add some neurectomy of the posterior interosseous nerve, like the nervation.
Mireia, I have 2 cases that I did like a remplissage, similar to shoulder, and I put the capsule with an anchor, of course, with a little limitation, but protect this area to the cartilage, especially in the dorsal part of the luna. It's very frequent to see in the pre-lunar fracture location or high energy trauma. So you can resort in that moment to put. It's not very easy to do it. It's the same concept of remplissage to protect the dorsal part.
A flap of the dorsal capsule,
Exactly.
reinserted.
Exactly. You put the capsule inside the defect.
We have one last question from the chat. I think there is a mistake. Eleni from Greece asks us, do you ever use auricular, that I think it's articular cartilage, as a source of chondrocyte combined with the membrane? What do you think about this? Maybe a scaffold for...
I think it could be the better option if you have the original cells, but it's too expensive to think about it.
Okay. Lorenzo?
To harvest chondrocytes and graft it with a membrane?
Yes, so, I think it means like a scaffold, so yes, it can be, yes.
We feed in glue.
Okay, no, I have no experience. What I've done is what I was talking about. If you harvest some bits of, what I usually do is harvest the tip of the ulnar head, just like a wafer, but with the cartilage of the ulnar head, which is more or less useless, and mix it with fibrin glue or PRP or whatever to create a paste, and then put it on the chondral lesion.
Actually, the Eleni is telling us is auricular from the ear.
Ah.
Someone has any experience for? No, you don't have. Because I was thinking it was a mistake. Sorry, Eleni, you don't have any experience.
No, but
maybe.
there are a device in Italy, I guess, that probably, I don't know, Andrea, if you know what, because there are a special device to take the cartilage from here, from the ear, to process this cartilage and introduce in the joint.
I've heard of this technique, but I have no experience on that, unfortunately.
Thank you.
I think in my hospital, the knee group, they actually harvest the cells during the arthroscopy of the knee, and then they send it off to Sweden, and then 6 weeks later they put the paste in with the cells. So it is done, but I don't think for small joints yet. It's done for big joints.
Maybe it's expensive also.
It's probably very expensive, yes.
It's for the biggest. It's the largest. For example, the hip, the knees is usual use this kind of things because we don't have enough option, and this is the problem. That problem of the knees. Imagine the big lesion. I think the wrist don't have this problem.
Okay, so let's switch to a really challenging part, and we'll challenge the humility of all the surgeons here because we are talking about the failures and how they manage it. So Andrea, please come with us. And we have, by the way, 5 brilliant candidates for questions of the panel in the front row, so we'll try to challenge them, if you mind, Andrea.
No, but hello, good afternoon, everyone. Well, actually, I'm not going to challenge, but to challenge everyone. So you scare me, huh? Definitely. Okay. So I was asked to give food for thought about the problems around the distal ulna. So this is the guys. They showed up in my office. He defined himself as a heavy laborer. In fact, he was the chef of the national ski team. So he has to follow all the Olympic winter athletes in the tour, and it was cooking for them. It's a very demanding job indeed. And he had this on a wrist pain starting about post a fall that occurred about 9 months earlier. So the appearance was a kind of inflamed ulnar head, prominent ulnar head possibly, with some point tenderness in the foveal area. And it was also tender over the first compartment. But I would like to draw your attention on the spatial position where his wrist was. So obviously, he arrived with the standard imaging in 2024, which is the MRI, of course. So the MRI showed these images here. So actually, it was very, there was a lot of fluid around the ulna. The insertion of the radio-ulnar ligament cannot be recognized precisely, and that's in the coronal view, and instead in the transverse view, we had this image, and yeah, the ulnar head look inside the joint. So the question is he okay, ready to make a diagnosis? What's your idea? Would you recommend other investigation? What would you do as a first approach?
You have to choose one of the victims.
No, a victim. Should I kill one? I don't want to be, I want to be a gentleman, so the first guy, please. Yes, absolutely.
Is the mic on?
Well, I guess you could start with a clinical examination of the patient.
Yeah.
Like stability testing. And maybe plain x-rays would be helpful as well.
Yeah, I agree with you, no doubt. The X-ray in first sight, they show you the overall image. And you see, do you note any particular detail that catch your attention? Ready. Okay.
I think that there is an ulna plus.
Something like that? Yeah, more or less. Okay, good. It was about something less than 4 millimeters. Okay. So what do you think? Do you think about any pathology? You can just give us a provisional diagnosis?
So we have two possibilities, because you can have the conflict of the ulna and the lunate, and also the TFCC foveator. So.
Okay. So we expect to find this kind of scenario. So are you good? Would you like to make some procedure would you recommend a surgery for this guy, or you need something more? What's the next step?
We can start with the arthroscopy.
Yeah, definitely. Arthroscopy. You are in the right place, definitely. So this is to show you how I found. Actually, it was even more synovitis than that. So it was everything full with synovitis. That's why they were discussing earlier. The synovitis on the side of the wrist may be a problem. But there was a very large central tear, and you can see some damage of the lunotriquetral area here, actually with the flap of the membranous portion of the lunotriqueter. This is an attempt of hook test. You see that hook is very strong. You can displace the wrist but not elevate the TFCC, but instead they have a peripheral tear, as you see here. And just to speed up a bit, I continue to clean, and I found also a tear in the palmar aspect, right here. Okay. In this portion, there was a large tear of the ulnar carpal ligament that I'm debriding here. So almost on the radiolunate ligament, but it's the ulnar-lunate ligament. and you can see also a big flap, this big flap of sclerotic ligament. Okay, I think it's enough. So we can suspect for sure, by diagnosis, we have a tear of the central disc. Next step is to stage this tear along the standard progression of the disease. So what will you do now? You scope in radiocarpal joint, because you started from radiocarpal joint.
I will go for the wafer procedure over there.
Right now. So you can stage this damage as a grade Palmer 2A or 2E or 2D. So the progression is that?
Progression to C? Oh no, there is the lesion on the lunate, so it's 2B, 2D.
Mm-hmm. Can anyone help him? Fantastic Queen, thinking. The next step to improve your diagnosis.
Yeah, you can go mid-carpal.
Yes, you got it. That's right. That's what we did. I did. Well, so this is the lunotriquetral joint. We introduced the probe. It was not opening. So that stage is a class 2C, right? So damage on the lunate, but no damage of the lunotriquetral joint. So this is a quite difficult case, because the same case we have several diagnoses like this. Okay, right. So Palmar 2C, a tear of the dorsal capsular ligamentous. So in Palmar 1B, peripheral tear, a tear of the palmar ulnocarpal ligament. So what can be the surgical options, the treatment?
So, for example, to shorten the ulna, or
Sorry, just press once, not for every word, just press once, not. Okay, so, well, we can have option for ulnar shortening or a wafer resection of the ulnar head, but we also have to manage all this, the other damages. So an upper repair would be required, or an arthroscopic repair. Are we okay in making the decision, right? Would be useful to get back to the X-rays?
You said in the beginning that the ulnar head was kind of prominent. Was it unstable in the beginning?
No. No, okay. And the hook test was also, like pulling the foveal insertion was stable.
I'm a little bit concerned about the ulnar deviation of the carpus that you showed before.
It was in radial deviation.
Radial deviation, sorry.
Yes,
so
and you have a reason for that.
Yeah, so maybe assess the extrinsic ligament between the radius and the carpus, or try
the
to
extrinsic ligament, they were fine.
Try to find all the tears that can explain this huge
No,
deviation.
it's a protective posture. And so you can explain also why he had tenderness on the radial styloid area. Why?
Because there's a conflict with the scaphoid to the...
No, usually happens because they have an hypertonicity of the tendon of the first compartment, because the tendons of the first compartment are keeping the wrist in radial deviation. That's why they become painful. So not the curved veins, but simply an overuse on that area. But if I give you a suggestion, I would get back to the X-rays before deciding if ulnar shortening could be appropriate or not. And why do I say that? For this reason, okay, we can think that the ulnar head is not always, the sigmoid notch is not three different types of orientation. In this case, we probably have a type C, or the X-ray show that. So if we perform the ulnar resection, we can cause an overpressure and we can cause pain. Okay? So the strategy could be, I'll show you what I did. I started from managing the tear or the palmar tear using a percutaneous suture. The needle goes ulnar to the ulnar-lunate ligament, and it goes palmar to the anacarpal ligament towards the actually testu ligament. We are about in that area. So the suture is passed with a needle and is catch with this very tricky solution. So you have this suture that goes making a side-to-side repair from the ulnar side to the radialmost part of the ulnar carpal ligament, and then we can make a sliding knot to tighten the ligament this way. Okay. And then what to do with this prominent ulna? We start the resection. What instrument am I using now?
The burr? No, the shaver?
Are you sure? No? No. I'm using a shaver because actually I'm resecting a soft tissue, because the cartilage is the soft tissue that covers the bone. So if I use a burr, it will slip and will make the resection very, very difficult. After I remove the cartilage, I will be using the shaver, okay, just like this, okay. And then it's very interesting because we can find several loose bodies into the joint. You see here, probably, yeah. So this is a dry procedure. So you have to deal with the debris here that you can stop. You see in the DRUJ there were some loose bodies, like here, and extra loose bodies. So the arthroscopy was also good to debride the DRUJ to remove the synovitis from inside. Okay, so I performed the resection, as you see here. Now, next step is to manage the peripheral tears. Okay, what would you do? Open, close, mini open. I think this is the perfect indication to use an all-inside repair, which is proposed by Francisco de Piñal, and he goes with the technique that percutaneous sutures, the needle is just removed after it's introduced the first time, and then it enters the joint again to be deployed outside, and a sliding knot is made here. Okay, so there was this large tear. You will fix it with a suture? Yes, maybe two. Maybe two will be required. So I did this procedure. You see the tip of the needle just in the large tear, and it comes out. So you see, we are managing the ligament, which is detached from the capsule. Even if the disc is damaged, we can do the same anyway. So this is to finish the case with a sliding knot and all inside. Then I repair the most ulnar part here. You resect everything. So I show you the end, which is the intact foveal insertion, a peripheral continent part, and also the palmar aspect of the ulnar carpal ligament was tightened again. Okay, just to make you think about the clinical result was very good, very fast, because the patient need to get back to work very fast. These are the X-rays. It's very interesting to see that there are 2 levels of resection usually in the AP view, because when you perform this resection, the Westphal procedure, you make an oblique resection. So in fact, you're not damaging the opposite surfaces to the sigmoid notch, but you're following the normal rotation and proximal migration that we have of the radius in pronation. This is in another cases. I perform the CT scan. As you see very clearly the oblique direction. So don't get nervous with if the resection still seems like distal than you expected. So some final consideration. I think that arthroscopy allows for a minimally invasive approach, even in complex disorder of the ulnar wrist. The accurate staging of the damage is key to make an appropriate decision for the treatment. And the limited surgical damage may facilitate post-operative recovery, less pain, and more motion. It's an alternative to conventional open surgery. I thank you for your attention. I hope I make you think of this. Yeah? No question, right?
No, I have just a small question from the chat. Darshan from India, our colleague. Andrea, would you prefer to do the opposite side X-ray before designing the final plan?
The plain X-ray?
Opposite side X-ray.
The opposite side, but I think you already answered.
No, I don't think it's necessary.
Okay.
No.
You don't. I have just a question, Andrea. I'm sorry. Sorry.
I have another question and one comment. Do you perform comparative X-ray?
That is the same question. The same question of Darshan. Yes, Darshan, he asked this question.
Well, basically, no, I don't. Because I don't even perform preliminary surgery on the opposite wrist. This is not my aim, probably.
Andrea, I have just a question about the double procedure wafer plus repair of the TFC. In these kind of cases, we have a real small area where we can pass the sutures. And sometimes, do you have some advice? Sometimes with the PDS, it works like a wire that cuts butter, you know. We don't have enough place to put the sutures in the remaining area after the wafer. Do you have any problems sometimes, some issues?
No, because I try to respect the ligament. The ligament is long enough. The problem may be if, if you use a straight needle, you go into the disc. Okay, I don't like, it can be done, but I don't like going to the disc. I prefer to put the suture in the ligamentous part of the TFCC. So.
And what's happening if the fovea is not there?
Sorry?
And what's happening? What is your plan if you have a foveal detachment?
Foveal detachment, unless you see very clearly the foveal insertion of this rupture with a lot of synovitis, and so I only repair in this case because patient the anaplast variant, constitutional anaplast variant, they have an hypermobile ulna. It's a physiological compensation for having a high ulna. So the ulna tends to displace in pronation to avoid a conflict against the carpus. So I don't try to fix the hypermobility of the ulnar head in anaplast variant.
Okay. Thank you.
Thank you. Thank you, guys.
Thank you. I invite Greg Bain. Greg Bain will speak about distal radius, a distal radius case.
Thank you very much. It's a great pleasure to be here. I think this is a really nice format, particularly to finish this meeting, to be able to share some of these cases. Can I get you to connect up my power? Can you connect this up? All right, thank you. So this is a 25-year-old gentleman who had a fall from a ladder. He sustained a fracture of his distal radius, and the carpus just looks a little bit unusual. It's always bad to sit in the front row, isn't it? Do you want to make some comments about what you see here?
So we have the volar Barton fracture. It looks like something like this. And it's probably the perilunate luxation. I would need more scans.
Good, so you do some more scans and you... Wait a minute. There we go.
Impresses him.
There you go. You got a nice image there. Does that help you now?
Yeah.
So go in, it's not great brain, you're okay, it's just a friend. Get that
So I think that we have
We haven't started with any tough questions.
Yeah, it's okay.
It's a subluxation, it's a full luxation of the lunate.
So you're going to put a plate on it?
Plate, yeah.
Arthroscopically assisted?
Yeah.
Okay. Anyone else in the front row? I think you're going to do that. Okay, we're going to do that. So you can see here the treatment, and this is the outcome. So it's been managed with also an open reduction internal fixation. It was done by the trauma unit in my hospital, who don't tend to use arthroscopy. They've put a plate on there, one of the plates available in the market. The patient told me sometime later, when I first saw him, he felt like his wrist had been put on back to front. It's the only time I've ever heard a patient say that. Any comments from the faculty?
Greg, probably a disruption of the volar ligaments.
Approximately what?
Excuse me?
What was that? Say, can you repeat that?
I think that probably in this fracture you have suffered some disruption of the volar ligaments, probably the radius scaphocapitate or something similar. You have a key fragment. This is the lunate fragment having probably the ulnocarpal, the short ulnocarpal ligament, but the other one, especially the patient said that he suffered the feeling that putting the joint back again, it means that probably he has a ligament injury associated to the fracture.
Good, excellent. So I think we should be...
He's not a student.
He's not a student, okay. He would have only just passed maybe. I thought the distal radioulnar joint looked a bit weird to me. The distal radioulnar joint looks open and it looks, ulnar looks dorsally subluxated, but the patient turned up in my clinic. It's the first time I saw him at 4 months. What do we think now?
We have the shift of the wrist to the ulnar side.
Okay. There's a ulnar translocation of the carpus. Okay. So what's normal?
It's normal. No, nothing's normal. Distal ulnar joint looks the best.
If less than 40% is uncovered, so 40% is off to the ulnar side and not supported by the radius, that can be normal. So on the top image, that looks pretty normal. On the bottom image, it's something like 70-80% is not on the radius. It's actually now sitting on the ulnar, so that's very abnormal. Why has this occurred?
Because the radial lunate ligament is there. So
radial lunate, yes. Any other comments?
Maybe we can involve the other participants. They are hiding in the last row over there.
They're trying to speak in the front row. I'll give them one chance here. All right, up the back then.
So can I choose one?
Yes.
For instance, Professor Matoula, what would be your feeling?
Yes, it is a very interesting case, and I suppose the extrinsic ligament, volar extrinsic ligament are detached. And it's why the wrist arthroscopy is essential in this kind of treatment, because you can open less and you can see more.
So you're very lucky. We got some extra imaging just for you. All of a sudden it gets a lot harder. Even I was surprised to see how bad this looked. Lucky Jan's come in just at the right moment. No, we've got to go to the back row. Francesca.
Please. Or Alejandro also. You help each other.
It looks like a Plind injury, non-diagnosed. So now you have like the disease completely dorsal. The scaphoid it has a translation, and all the volar ligaments are destroyed.
Right. I want you to go back one step. What does Plind mean? What is it? What's that acronym mean?
Like perilunate non-dislocated injury.
Is this a non-dislocated injury?
Well, now it's dislocated, but at the beginning it was not.
Right. I'm partly responsible for the Plind the concept. But no, so you're right. So actually the whole concept of there being little avulsions and things is a very important concept. It's really critical, and that does explain what's going on here. So now we've got this massive ulnar translocation, even looks worse than what we saw on those other images. And then where are we now? So treatment. So what I'm going to do is just show you where I think the zone of injury is. It's interesting to see how the zone of injury goes to the lunate facet, which we said. What other ligaments are torn here? Professor Mutherland did describe it partly. Anybody?
Here, Abdelrahman, you have something to say, because he wants to...
He wants to
answer.
The volar radioscaphocapitate, possibly, and maybe the TFC, I think. Because the DRUJ joint is...
DRUJ is dislocated.
Yes, so the DRUJ ligament's probably also injured.
It's got to be gone, doesn't it?
Yeah.
So you mean everything is a mess?
Well, that's why we have arthroscope to check.
Everything's a mess. All right, so the concept of the volar carpal ligaments being torn is a really important one. And so this is now on the radial side. This is a radial styloid. And this is a different patient, but the similar concepts. And I'll bring it in to almost say that it can be the radial or ulnar side and the volar side. So it's a motorbike injury, wrist dislocation. He's got a radial styloid fracture. It doesn't look too bad. This is his arthroscopy on the bottom right. You can see the radial styloid to your right. All the volar carpal ligaments look beautiful, but it's fractured. And then as you go across to the lunate facet, there's a big rent. The entire lunate facet, soft tissues are not attached to the lunate facet. So there's what I call it a sleeper lesion. So you've got the radial styloid gone, and all the ligaments on the volar side are completely gone, proven at arthroscopy. And so the concept of a sleeper lesion is here, like you've got this little volar rim avulsion, and you get this little bit of dust, this fine dust avulsion fractures. It's actually the same concept as the Plind, I think, but basically what we noticed was that these fractures tend to go into like a sharp point. So as it pulls off, it's that sharp point, and then the soft tissues go with it. We term this a crescent, rim crescent fracture. So it's this oblique type fracture with a sharp edge. And so a sleeper lesion is a lesion of stabilising structures held together by the secondary restraints. It's unmasked with time and also loading. So we saw before that example where you had the case that it was not displaced and then it became displaced. And when you're going to see it, the patient has a high risk when they've got a high energy injury, a dislocation, and there's a lot of swelling. So this is what we think happens with this case, with the radial styloid, with the lunate facet, sorry. Get the volar instability, scaphoid instability can occur, DRUJ, and it goes to the long radiolunate ligament. What's the natural history of this wrist now?
Osteoarthritis.
Anyone from the back? Is that right? It doesn't look that bad, does it?
Osteoarthritis, yeah.
Sorry? It comes like this. So this case might have, this is a different case, but the volar carpal ligaments are torn. The lunate has degenerative osteoarthritis, and the lunate facet on the volar aspect has full thickness articular cartilage loss. And the other part of the mechanism of injury is the dorsal radiocarpal ligament must be torn. And the reason it gets progressive degenerative osteoarthritis is this volar ulnar corner, where the loading is an abnormal position for that to occur, and the patient gets degenerative osteoarthritis. So the case, back to the case, this is what I think is going on. We've already talked before the other day about how this is associated with the volar subluxation of the carpus and these complex carpal injuries, and at arthroscopy that we can identify these soft tissue ligament injuries. We've already heard before how Dr. Kurilla's got some beautiful techniques of how to stabilise it. Let's just go past this. I just want to get back to this case. What are we going to do now? What do we do now with this case?
We cry.
We try, but we cry, maybe. Now, since we have osteoarthritis, are we maybe too late right now?
So we're at 4 months.
Maybe we have to ask to those guys if you can make nanofractures for the... No? Not yet? Oh. So I'm desperate.
Jan?
I think it's over. You have to do some kind of salvage.
Okay.
I would fuse the radius to the lunate, and then I will look for the distal radial ulnar joint after that.
At 4 months, 25-year-old.
It won't stay. You're not able to stabilize it.
Martin? It's reasonably, well, everything's reducible with a...
Bearing zone in oh, sorry. I guess that probably the critical area will destroy the cartilage in the critical zone to bear in the lowering of the wrist. So we have to analyze that. Maybe if you can change this distribution of force, this is a possibility, and to restore the rings. Thinking about in the ring theory, that is very helpful introduced to manage this type of lesion.
Greg, we have someone online tells you first maybe only remove the plate. What could you answer to?
That's a good idea.
I don't know. Maybe
we actually we tend to remove the plate and do further imaging, and it gives us a chance to see what's going on. Maybe some biopsies, arthroscopic debridement, see how bad the joint surface is. So I don't have a problem with that, but I think you still need to be moving forward. Gustavo.
Just a comment about possibilities for reconstruction. It's of course is a rare condition, it's not common, but we had experience with brachyradialis reconstruction for the radius scaphocapitate ligament for medial translation. It's a published technique, few cases of course, but it's an option. The doubt of course is if it's worthy in this kind of arthritis, but considering the discussion before of young patients and trying to postpone any salvage procedure, it's something to think about.
So you take the brachioradialis, leave it distally attached, and do you wrap it around the carpus or around the capitate?
No, we made a tunnel, a straight tunnel in the middle of the capitate, and we harvest the brachioradialis, keep it the insertion in the styloid tip in the styloid, and we cross it to the mid-carpal and the capitate, go outside, and we suture it back into the same area.
Like a ring.
Okay. Do you do it arthroscopically? No. So I wondered whether this was my plan to remove the plate and do a radial osteotomy to flatten the inclination, do a major release of all the soft tissues, and then put the TFC back and repair it. We did some work some years ago to be able to identify exactly where the ligaments are, and that helps identify where all the different aspects are. In the interest of time, shall I continue on? And then we like to go through what we refer to as a volar ulnar approach. So because it's had the previous approach through the FCR bed, when you go through the volar ulnar approach, it makes it all reasonably clean. I actually recommend that to you. And we effectively went to flatten the distal radius, so it's down to, we aimed at 13, we were at 13 degrees and we aimed to get back to 13 degrees in the AP plane and 2 degrees in the lateral plane. You can see the volar aspect with the distal radius, and you can see the osteotomy. So we've released all the capsule, you've got the radius there, and we've performed our osteotomy and we're plating that. That's the position. So you can see this is reasonably flat. This is almost flat, and we've done a TFC repair as well. At this point in time, I'm thinking I've done pretty well. I've achieved my primary goals of surgery. The lunate looks unbelievably good on that lunate facet, and I'm thinking I've salvaged a complex problem. But
There is this is the magic of the Zoom. Darshan, our colleague from India, has exactly the same idea. He told us an extra-articular procedure will correct the deformity and reduce the joint erection forces at the lunate fossa.
good.
So now we will see.
That they are very smart. Were they smarter than me? They were not smarter than me. Because here we are at 1 week. The lunate translocations reoccurred. And so I must admit I was a little devastated at this point because I thought that we had done a great job. What do we do now? Yeah, yes, thanks. I just didn't want you falling asleep there.
I mean, what's the patient's goal at this point? I think that at this point I would pause in saying, do I actually need to operate more to make you better, or do I need to pause and see what the natural history of this ends up being over the coming few months? Because clearly there is a ligamentous disruption that was not addressed with only correcting the bony deformity, but addressing that ligamentous disruption may make his x-ray look better in the immediate term. Depends on what his goals are in the immediate term. So I would
Any other
pause.
comments? Jan?
No, in my experience, it will not hold. Whatever you do, it looks good in the X-ray, but the patient will come back within 3 to 6 months, and you have the same problem.
Okay.
This is not. You cannot solve this.
I'd invested far too much. I wasn't going to give up now. So I took him back to the operating theatre within a day or two, and did a closed reduction effectively, but in a bridging plate. So that's open, of course. And there's my bridging plate. Who's happy with that? It's a bridging plate without reduction. So I then manipulated the position of it all, put the carpus back. It actually lined up pretty well. I'm thinking I'm back in the good books again. And then I've moved it there, and then changed all the screws around to get all that. Is that it? And then I put some. This is the super Linshire deal. This is the Linshire deal that you've never seen before. I've got stability. I've got reduction. I've got I've got alignment. It's meant to be one of the more difficult cases, right? This is the whole topic. I've got alignment. I actually think I'm not too bad. Thanks, Jan, for taking the photo. Make it a video, it might be better. All right, so at 6 months, here we are. So when I look at this now, I go joint space narrowing, it's a bit of a problem. Ulnar translocations partly reoccurred. DOUJ actually looks pretty good. And he tells me that his wrist is not back to front. So he's back at work. He's reasonably happy. I need to do some further follow-up x-rays. I think what we'll find is the scaphoid facet will be a problem. Now, what I want to go back and do is I want to go back to the forest. You must look at this x-ray again, because the problem is not getting it right the first time. So when they did this, they put the plate in the right position. They underestimated the importance of the soft tissues. If you look here, where are we? Have you got that? On between the, I don't know if my laser point there. If you look here, the lunate is sitting on this fragment, but the scaphoid is not captured at all. So all of you said the lunate was unstable. No one mentioned the scaphoid, I don't think. So the scaphoid is unstable as well. It's not, in fact, the scaphoid is more unstable than the lunate. At least the lunate's got the lunate facet to hold it. The scaphoid's got nothing. And this little volar fracture fragments with sleeper lesion is a really important concept that I think we need to all be aware of, and it's all part of the concept of osteoligamentous units. I think I'm finished.
Quick question.
Yep.
Do you think, in terms of identifying or better understanding the TRUJ instability, do you think there is any involvement of the distal oblique band of the interosseous membrane here, ligament?
So I think, so for those who aren't familiar with this, a band of the distal part of the distal radial ulna of the interosseous membrane that spans across, George Orbay's promoted that as a concept, and particularly for very complex injuries, almost dissociations between the radius and the ulna. I think it's a real thing, but I think it's reasonably uncommon. And so I think usually you can address it with stabilisation of the triangular fibrocartilage complex. And for those cases, he's got a very nice little, almost, what's the proper name of that, where the whole wrist clunks over the top. Anyway, you need to look up his work, but it's a very interesting concept of how unstable that can be. Thank you very much. Oh, Jan, sorry.
Very much.
I have one comment. You started out asking what is the natural history of this. And I think you have been able to put it back after 3 major procedures. And you know there's one more, at least one more coming. So the question is, what does a 26-year-old man want in the beginning? You know what the final solution will be. The question is, for how long wants he to be immobilized, out of work, out of doing any activities, because you know what the final solution is going to be.
No, that's fair enough. At this point here, there's my thing's off. At that point where you've got that ulnar, this point here, there's a lot of surgeons that would say we should go to a radiolunate fusion, which is what you said. And at this point, I thought I could actually correct it. And so if you align the radius, then I think you can see how the lunate will tend to now drift back into its more normal position. But that's right at the edge of what our capabilities are, and certainly the edge of my capabilities.
I have a question.
If you had the chance of a second chance, what would you do with the same patient and you see him once again with the fresh trauma?
I'd send it to Jan. So the initial presentation, I think you need to still put the plate on, look at all the soft tissues, and address and suture those soft tissues. And I think that distal radial ulnar joint must have been unstable at the time of presentation.
Provocative question: arthroscopically or open?
So, I think we're at an arthroscopic congress here, and that's important. But I think what's more important than whether it's done arthroscopically is that it's addressed, identified. Most times it's not even on this surgeon, it was not part of their understanding of the problem. And so in fact the whole point of this case is to raise awareness of the importance of the soft tissue injuries and the sleeper lesions. Margaret.
Just wondering, when you do the first operation for you, when you do the first operation, after you put the plate on, did you check the stability and did you see that it was quite stable? Because I'm just wondering, after 1 week it goes back. I mean, did you actually think that at that time intra-op it was quite stable?
So at that point where I did that I released everything. Like it was a radical, a tumour operation, and so I thought I'd done the best I could at the time. I did actually think about a bridging plate. And the very few times in my career I've thought about a bridging plate and I didn't use it, every single time I didn't use a bridging plate, I've regretted it. And in fact, it's a little bit like doing a fasciotomy. We were all taught, when you think of doing a fasciotomy, do a fasciotomy. And I would say the same thing. If you think you might need to put a bridging plate on, put a bridging plate. So I think if I got the bridging plate right, and I still might have got that instability, because it wasn't until I actually put the super Lynchide pins in that I actually maintain that stability.
Okay. Thank you very much. Great. So now, Professor Lee. will share with us a case regarding scaphoid.
Okay, good afternoon. So scaphoid. So first of all, I thank the organizer here, all the names here, for making this special arrangement for us in this special anniversary, allowing us to gather here like never before. Thank you very much. So scaphoid fracture, I'm not going to present a really worse but impossible to encounter again for you, but it's not hold particular significance. I just present one of the most challenging cases, but many of you may encounter in the future. So this is a patient. 20 years old, it's an elite athlete, it's China national team, got some medals in Asian Championship, fell from 3 meters high in training. So apparently this is a badly displaced scaphoid with dislocation. It's a scaphoid peroneal injury. It's a young athlete, is eager to back to play. So we all know that the peroneal injury, high energy trauma, it could has a fracture or not. So the current practice, close reduction in the emergency room, and I will have a lot of debate on the approach, volar, dorsal, and combined approach to addressing the scaphoid fracture as well as the ligaments and the capsules. So, but it is clear that we all know that everyone in this room all know that the open procedure actually is not the ideal solution. So capsular scarring, stiffness, also the chance of a damage or already tenuous blood supply to scaphoid and torn ligament. So this is my my approach for the arthroscopic management for peroneal injury. So in an 8-year interval, I have 60 cases with follow-up, and you see actually is I think everyone here actually has known this approach. So my algorithm is we try single attempt of close reduction in the emergency room, but try to avoid repeated forcible close reduction, which may cause iatrogenic cartilage injury, which is shown here. So you cannot achieve close reduction, you can proceed to the arthroscopic assisted reduction of the dislocation. And after the reduction of under the traction force of the wrist arthroscopy, you can have the opportunity to reduce the dislocation, and the arthroscopic control can have a very good view to help you to achieve anatomic reduction of the scaphoid as well as the other couple bones. But remember that every patient in peroneal injury is different. Sometimes in simple case, 30 minutes. However, you can struggling in the operating room 4 hours. So life in the operating room, like always, like this. So back to this patient, the marked displays scaphoid fracture with dislocation. So actually you can see, if you're really looking at the CT scan, so I will not ask every one of you to answer the question because just take it. I just show you you're looking at the scaphoid, it's actually looking at CT scan, the proximal fragment rotate by 90 degrees, both in coronal and sagittal planes. So this is a floating proximal fragment. So what to do next? So we have an option of open, arthroscopic, hybrid. It's also possible we just do arthroscopic approach. So what do you think, Martin? We have a very good discussion today about this peroneal injury.
Yes, I usually start with the arthroscopy to evaluate all the situation, the two compartments, the radiocarpal compartment and mid-carpal joint, to evaluate. Maybe it's very tricky. It's like a little enucleation of the proximal porous scaphoid. So sometimes you have to evaluate who ligament or capsule are detaching in this fragment, but because it's one of the key factors of the behavior of this scaphoid.
Yeah, so Martin, you definitely you will think this is possible to do the arthroscopy approach. So actually I would say exactly what I'm thinking. I'm trying to, because of young athletes, eager to back to playing earlier. So this I operate. So you can see there's a distal scaphoid here, And then you can see the proximal fragment here is actually this fragment is grossly dislodged, and I can try to partially reduce it, and derotate it by 90 degrees with the fracture plane facing upwardly. Initially, it's facing volarly, but you can see it's a complete SL ligament disruption. It's a floating fragment. And then I further reduce the proximal fragment by using a bone holder to derotate another 90 degrees. And then you can see after I agree with Martin, after we release all these scar tissues and release all these soft tissue entrapped, then we can have opportunity to reduce it. And then arthroscopic control, fine-tune of the reduction of scaphoid fracture and the reduction of the SL and LT, and percutaneous fixation and pinning. This is after fixation. So also in this kind of patients, sometimes you may find it's difficult to put in the screw or key wires by manually. So in my center, I use a robotic fixation for both the fracture and dislocation. So the robot can assist you to achieve optimal implant trajectory for better biomechanical architecture of the implant of the implants. So, however, for this acute total disruption of SL and floating proximal scaphoid fracture, do we need any type of a dorsal SL complex repair or plication or capsular diastasis? I believe many of you actually in this course you have seen lots of procedures, so very fancy procedures. So, what do you think, Lorenzo? For this case, would you like to add some augmentation for the total disruption of the?
You mean when you have a perinate, do I do something on ligament repair?
This is acute, but also the proximal fragment is floating. Yeah.
Usually for acute perinate, I try to treat them arthroscopically, assisted, like represented, and I pin the bones, but I also do a repair, capsular repair.
Capsular repair, yeah.
Of the LT and the SL.
Yeah. So I agree with you. So for the this is a high-end trauma only that's not just X-rays. It's involved a lot of the ligament injury. So we have many solutions as I mentioned before. One of the solutions I use in the past few years, I extend the 3/4 portal a little bit and put two suture anchors on the scaphoid and the dorsal scaphoid and the neonate, and use the sutures and tie on top of the capsule as to reinforce the DCSS. And we also have another many options which you have seen in the 2 days, a lot of the dorsal SL complex application, augmentation with suture anchor or whatever. However, no dorsal SL complex repair or application performed at that time for this patient. So what's next? 32 months post-op. So she back to play quickly and won medals again in championships. So nothing done for the capsules. And
I have just one comment. Do you think it's the same way to have an acute injury which is fixed with key wires just like a cast, than another one that maybe lasts for months and months and that you need to make a repair? In my opinion, it's not mandatory to make a capsulodesis in acute injuries because it can heal by itself if you put it in the proper situation.
Yes, exactly. Because we restore all the bone back to the native anatomic position. As in acute setting, the soft tissue has a chance to heal well. So, like in this case, the patient can do the push-up and do this high demanding sports. So how about the long-term outcome for this kind of patients? So So this is the latest data collected just last month. We have in my around 80% of perineonate treated by this approach. 15 patients with mean 8 years follow-up. The longest follow-up is 12 years, all back to the previous occupation and sports. So these are some of the patients. This is one is 11 years post-op, 12 years post-op. You can see that they have the reasonable functional outcome. So should we change our practice for perineal injuries, close reduction in emergency room? Yes, but just single attempt is our suggestion. So approach dorsal volar combined. Everybody here already knows that the arthroscopic approach is a viable and a reliable solution even in the long term or for challenging cases, with promising alternative with satisfactory outcome. However, do we really need repair or application of the associated ligament injury in acute setting? I don't know, but I like the procedures here demonstrated, beautiful, fancy. Probably we can allow the patient has a quicker rehab. I think it's good. But is it a must to do so many complicated procedures to our patient? Probably we need more discussion, more thinking, or probably more research on this. So I think this is a wonderful place with an umbrella of the IWAS, IRCAD. We can have a lot of centers to work together to really do some multi-center research on this, which will eventually benefit to our patient. Yeah. Thank you very much.
Maybe you have some question from the chat, Alan?
Yes, so I have a question from Peter Jordan. I've had a recent transcaphoid perilunate case, had clear bone avulsion of DRC from distal radius, bone flake visible on the CT. Would you repair the DRC origin to the distal radius, or do you expect that to heal if risk reduced? The same.
Yes,
natural position.
Yeah, like I mentioned before. Probably I will think again now to look at the long-term results and the recovery status of the high-demanding patients. I will think about in acute setting, do we really need the complete procedure to repair all these ligaments? Probably I will agree with Martin and many of others. Probably I will just do some minimal, not too much. Yeah.
Well, I have a quick answer for you. You use frequent bone grafts in this type of comminution fracture is another.
Yeah, thank you. It's a great question. Yeah, I do use several, but not much. We would say we all see that the acute fracture with some bone loss. So if the loss is significant, probably I will use. But in most, this is not non-union. Like a non-union case, the chance, the potential of healing is quite high. So I just use very, very few cases.
Okay, we are going to finish. An applause to
So
we close this session at forum. Okay.
So once again, thank you to everyone, Martin, Xia, Lucian for organizing. Thank you to many thanks to all the participants for coming and staying until now, all the faculty, and I hope to see you soon in March for some of the faculty, and very soon for the advanced and the master course for the basic course participant. Thank you.